Good afternoon. My name is Maureen Corcoran, and this afternoon, I and my colleagues from the Department of Medicaid are going to share with you an interesting and we think pretty exciting update about what we're doing in the world of telehealth. Next slide. We've gotten a lot of feedback from many of you, which has just been fantastic. And I want to just use this as an opportunity to say thank you for all of the work that you do and to just remind us again, we are all in this together. I particularly appreciate some of the stories that you have shared about how telehealth has affected your work, how you perform your practice, how you organize your office, the kind of services, the kind of additional care that you've been able to provide or have facilitated because of this. And we all appreciate hearing some of the ways that it's really made a significant difference in people's lives. So thank you for that. Through the webinar today, you can enter your questions into the chat box. I have a number of experts with me to help. And at the end of the presentation, we'll also give you a link to a mailbox so that you can, if there are other questions you think of, we'll try to answer as many as we can. And then if there are others, you can send those in to us. Next slide. Next slide. All right, so telehealth is actually sort of the silver lining to this COVID pandemic. Early on, at the very beginning of the pandemic, the governor challenged all of us across the entire cabinet to respond aggressively and quickly. And so at a very high level, this is just a few points about some of the work that Medicaid undertook in order to respond to that challenge. So obviously we're here today to talk about expanded telehealth services across the board: behavioral health, medical, clinical, dentist, you'll see across the variety of different kinds of providers. And embedded in that is easing up on some of the technological restrictions that previously governed the way in which telehealth could be used. Temporarily reducing prior authorization requirements across our services in order to not let that be a stopping point or a barrier to folks getting the care that they needed. We eliminated a number of in and out of network restrictions and pharmaceutical copayments, for example, while increasing pharmacy reimbursements for over-the-counter medications that previously weren't covered in order to be sure that during the pandemic, folks were getting what they needed. And we've enabled nursing home and congregate care members to access telehealth, for example, with no prior authorization. Next slide. As I mentioned, we've heard a great deal from many of you. Since the governor signed the original executive order that authorized us to proceed with these relaxed requirements on telehealth, the feedback and the support has really been overwhelming. You should see here a quote from Dr. Stone with COPC. The relaxation of rules regarding telehealth has undoubtedly led to significantly better care for our patients during these challenging times. And that's exactly what we all have set out to do. And just a little bit of preliminary data. The early data that we have shows that telehealth utilization has skyrocketed during the initial months of the COVID pandemic, and that is really excellent news. So, for example, in the arena of our physical health, and I'll talk about behavioral health in a minute, but in the physical health arena, prior to COVID, we were seeing approximately 1,000 average claims per month. And since the pandemic, we're seeing about 200,000 claims per month, which is fantastic. In the behavioral health arena, the pattern is very similar. Prior to the pandemic, we were seeing about 4,000 claims per month, and now we're seeing, as of April, we are seeing 270,000 claims, which is, again, fantastic. Next slide. Next slide. Before we get into the specifics of the rules and the changes that we're making, I want to just put a little bit of a context forward for us, give you a little bit of a sense of what we're thinking about. So our goal or our vision through this change really has been to create a regulatory framework that expands clinically appropriate telehealth services while maintaining the fiscal sustainability and integrity of our Ohio Medicaid program. And like every other aspect of healthcare, it's a little bit of a balancing act, but the goals then are to maintain or improve the quality of care, enhance access for patients, and this is particularly helpful where it's maybe more rural or a limited number of specialists or people with a unique kind of expertise that maybe the patient has to travel a long distance for, to improve health outcomes, as well as to provide flexibility for providers and patients. Next slide. Stephen Alexander is going to talk to us now a little bit about the rule process that we're now beginning. So, Stephen.
Thanks, Director. Yeah, many of you might have seen yesterday, if you get Rule Watch or follow JCAR and rules that are original filed, that yesterday was the last day for us to be able to original file our telehealth rule in order to have it go and become effective by November 15th. So that happened yesterday. The rule is posted, and we'll have a link to it at the end of the slide presentation for you, in case you haven't found it in the Register of Ohio already. But the key takeaway is that we were able to file the rule and start the JCAR clock, if you will. So it's now before JCAR and their jurisdiction. We have to have, it's a Chapter 119 rule, so we will have a public hearing, and that is scheduled for October 1st, where any citizens or any interested parties can participate and offer comments. And then we'll final file the rule on November 5th if we get through JCAR and have it become effective. The emergency rule expires on the 14th, so we have timed this up as quickly as possible to be able to line things up, to be able to make this permanent rule become effective right the next day after the emergency rule expires. Next slide. And I'll turn it back over to you, Director.
So as you know, there are the value or the benefit of telehealth is really across the spectrum of our services. So there are many, many rules that are also affected by this first reimbursement rule that we're talking about. And so we're not going to go through all of those today, but just to summarize at a high level, for example, in the arena of long-term service and supports, there are about 80 rules regarding HCBS, nursing facilities, assisted living, home health, private duty, and hospice. Those rules will need to be modified in order to align with this new rule so that we can continue to go forward. And it retains the provisions of the emergency rule in order to allow telehealth when clinically appropriate. So watch for those of you who work in those different areas that we know that you follow the rule processes, and you'll see some of these rules come through with sufficient minor changes in order to enable the rules to continue. In the area of community behavioral health, similarly, we are retaining the emergency rule provisions to ensure that telehealth services are allowed. We are removing the requirement for a face-to-face evaluation and removing the prohibition on services being delivered using telephone or video conference. Further, there is some additional greater flexibility around fidelity reviews for ACT and IHBT providers. In the area of our outpatient hospital behavioral health rule changes, similarly, there will be some continuation or reinforcement of these provisions going forward, as well as some clarification related to the behavioral health outpatient policies. We would ask for a little bit of your patience. There are many, many rules here, as I mentioned. Some of them will have to go through different kinds of processes. They don't all go through exactly the same evaluation process. So we're working feverishly to try to get them all through. But this first most pivotal being the reimbursement rule will enable you to continue to provide services in the meantime. Next slide. Next slide. One little bit of caution that I want to offer before we get into more of the specificity around this particular rule is just to flag for everyone that some of the flexibilities that we have been able to take advantage of are because of the federal declaration of the pandemic. So while there are many flexibilities that are under our control at a state level, either through our state law and practice or scope of practice laws, as well as things that we say in this arena, Medicaid can negotiate with CMS, there are some additional flexibilities that are because of the pandemic. And so we are continuing to request and seek clarification federally to see how HHS intends to approach all of these areas that will have a bearing on us, and to see then what changes will be needed as we come out of the pandemic. And most notable, of course, is this example here, HHS and the Office of Civil Rights in particular as it relates to HIPAA. So for example, today now, under our current rules and process, for example, a practitioner can FaceTime with a client and be able to provide a service and bill for that. FaceTime is one of those kinds of mechanisms that would not typically be allowed under the federal HIPAA requirements. So just to give you that as an example. And we're trying to make a good assessment of that and be in touch with our congressional delegation in order to, like we are, to encourage them to give us as much flexibility as possible. But that's just a little bit of a caution. So these are permanent rules that will go into effect on the timeline, as Stephen said, and they'll continue through and beyond the end of the pandemic. And depending on what happens with the federal guidance, we may have to make some changes associated with that, but clearly that's not our desire. Next slide. So Stephen's going to walk us through now the major components of this rule and what's primarily focusing on what is changing with the permanent filing. Stephen?
Thanks. Yeah, so on this slide, we have a few of the tweaks that were made to the definitions. And I think the key point to take away as we walk through some of the changes is there really aren't many from the emergency rule to this permanent rule we filed. So the key takeaway with respect to defining telehealth in the permanent rule is that we're maintaining the asynchronous communication options. So it doesn't have to be real-time audio-visual in order to be able to receive reimbursement. So we did include in the definition of telehealth explicitly mentioned remote patient monitoring. We did remove fax as a communication medium. We did add to the definition of telehealth that the communication transfer can occur through the secure patient portal that the provider might operate. And then you may recall when the DeWine administration began, when Governor DeWine took over, the telehealth rule for Medicaid at the time had a very narrow list of places where the patient and the practitioner could be in order for the telehealth service to be able to be reimbursed by Medicaid. And on July 4th, 2019, Medicaid enacted a rule, it became effective, that expanded that list significantly. The emergency rule did away with those restrictions, and the permanent rule is maintaining that from the emergency rule. So the list that sort of restricts the patient and practitioner locations before you can render telehealth and have it be reimbursed with Medicaid, those are gone. So that should be good news. And then regarding telephone-only service codes, there were 3 of them that we had in the emergency rule, and we're maintaining 2 of them. So 99441 and 442 is still going to be able to be reimbursed. So telephone-only telehealth will still be able to be reimbursed by Medicaid. Next slide. Regarding eligible providers, another key takeaway, very few changes. So we're maintaining the eligible providers from the emergency rule. So few additions. audiology board individuals who have a conditional license, that was added, and I believe that was based on some stakeholder feedback we received. And another new practitioner type that we're adding to the telehealth rule is optometrists. We had several of our policy folks talk with them and go through some codes and discuss how they might practice, and we were able to add it to the rule in time. So we were very excited about that. And then outpatient hospitals, we did make some changes. They're still on the list, but they're going to be able to render services and bill only for outpatient hospital behavioral health services, and then for services that they're rendering on behalf of licensed psychologists and independent behavioral health practitioners. So if you're a physician or a PA or another type of practitioner who's rendering telehealth on that site, those professional services can still be billed. But this is specific for when the outpatient hospital is billing as the provider directly. So next slide. Yeah, on provider responsibilities, again, very few changes. But you may recall from the last version of the permanent rule that became effective last July in 2019, there was a requirement that the telehealth provider or someone that they work with, someone else in their clinic or hospital, had to see the patient in person annually. And so we're not bringing that completely back, but we do still have in this iteration of the permanent rule a requirement that the patient has to be seen annually in person, but it doesn't have to be by the telehealth provider. It can be a provider who's usually responsible for delivering clinical care, just not the emergency room. It is one requirement we put in there. And then other dot point there on this slide is we added a provision that simply states that if you're rendering telehealth, you have to be doing it in accordance with your licensing board. So we expect that you would already be doing this anyway. But if some licensing boards might have certain requirements or a certificate you might have to get before you can render telehealth. So if that is something that you're required to do by your licensing board before you can bill Medicaid for it, we simply want to make sure that you're adhering to those restrictions. But again, we expect you already would be. Next slide. So services eligible for telehealth. Again, not that many. Key takeaway that I want to highlight is the consultation E&M codes still can be billed. We're retaining that. So that was a big piece of feedback we received from a lot of providers, a lot of patients, that it was very helpful. So we're keeping that. End-stage renal disease is remaining, but we changed the terminology to dialysis-related services, and that was just to clarify that, avoid some of the confusion about when can I bill telehealth services. Dialysis-related services is a bit more inclusive, so we retained that, and you'll see that reflected in the appendix. Those codes are still there, just a little bit of the nomenclature is a little bit different, but the relevant codes are still there. Again, we have some optometry services that we added. This goes along with us adding optometrists to the list of providers who can render telehealth and bill Medicaid for telehealth. So those E&M codes, the consultation E&M codes, they'll be able to bill similar to other practitioners, but also we added some specific optometry codes for them as well that are unique to their profession. And then a few other services. If you go through the appendix, you'll see a couple things that are added. Periodic oral evaluation as a covered telehealth dental service. Interactive complexity was not previously included in the emergency rule. It is now. So a few additions, but again, largely keeping things the same from the emergency rule. Next slide. And then conditions of payment, again, very few changes. We removed the provision from the emergency rule that allowed for the telehealth or site origination fee to be billed. So that code is gone, but the services rendered will still be able to be billed. And then we added a requirement regarding claim submission, just clarifying some things like the GT modifier needs to be used and some other basic sort of claims submission guidelines that have to be followed, not unlike any other type of requirement. If you're filing claims, you just has to be done in a certain standardized way. Director?
Okay, next slide. Thanks. So we've got, that's the presentation. We've got questions coming in through the chat. I'm going to ask Patrick and some of our team to tee up some of the Q&A for you. And I'll just leave here on the screen for you the access or the link to the rule that Stephen mentioned, as well as here is our email if there are questions you have or clarification that you'd like after today's webinar. So Patrick, can Kevin and Michael, can you let Patrick open up his mic, and let's see if we can answer some questions.
Let's see, I'll scroll through some of the questions here. I'm having a little difficulty getting my window to expand. Are there any types of services or subspecialty visits that are not appropriate for audio-only telehealth patient encounters? Example, if audio only, how would a dermatologist evaluate skin complaint or concern? There are going to be certain types of services that are not appropriate for audio only, and I think your example is one of those. I think what we'll need to do is take this question back to see if we have a list or an explanation as to what types of services with some examples. But yes, that is one. For therapy and other services, can those not billed on a hospital UB form? Can those not be billed on a hospital UB form only as professional fees?
Hey, Patrick, this is Lynn. I can help answer that question.
Thank you.
So the the outpatient hospital billing that Stephen described earlier, there are two options for outpatient hospital telehealth services to be billed to Medicaid. And I think I hear some typing in the background, so if everyone can make sure their phones are on mute. So the two options for outpatient hospital billing for behavioral health services, hospitals may bill services that are covered under the Medicaid outpatient hospital behavioral health benefit. So we call that the OPH-BH benefit. So hospitals on the line should be familiar with that, and there's more detail in the rule about that. The other instance in which a hospital could submit a hospital facility claim would be for therapy and services provided by licensed psychologists as well as independent behavioral health professionals. So those are professionals that cannot submit a professional claim when they're employed and operating within an outpatient hospital setting. So the hospital can submit claims for those services using the hospital UB form.
Okay, and then there's one question here that only states, is that effective now for interactive complexity? I'm not sure I understand the question.
Hey, Patrick, this is Lynn. I think I can help with that as well. I believe the question asked is pertaining to the effective date for the addition of the coverage of the service called interactive complexity. And that will be effective with the effective date of this new rule, which I believe, Stephen, you indicated would be November 15th.
Yeah, that's correct. November 15th being the effective date for this rule package, with this service being added through this rule package, that will be the effective date for that service as well.
Okay, thanks.
The next question. I work for a community mental health provider which provides crisis services, but not ongoing care. Some of these services are being provided virtually currently. How will the requirement to see the patient in person at least once annually apply to this care environment? I think that goes back to some of the observations that Stephen had earlier as it relates to the once a year requirement, that it can be another practitioner.
Yeah, it can definitely be another practitioner. And I do want to stress it is an expansion and making it more broad from the previous version of the permanent rule that we had adopted, you know, and that went effect on July 4th. So under that version, I think it would have had to be the provider, the same provider who would have to see them once a year. So, you know, I think it's mostly geared towards people who would be seeing folks on an ongoing basis, but really we just want to make sure that people are being seen in person, semi-frequently and not just going to the emergency department. So we would expect that, if you run into any issues, let us know, but we can definitely examine further how you guys might be impacted and have that conversation. Feel free to send us some of the details through the rules email address, and we can sort of troubleshoot. I don't know if Lynn, if you know offhand how that would work, but certainly our intent is that we would want to make sure that critical care services were available to people.
Next question, what about texting? Texting is not covered under the definition of telehealth. Following activities that are asynchronous or that do not have both audio and video elements include telephone calls, remote patient monitoring, and communication through a secured electronic mail or secure patient portal.
Yeah, and I'm not sure that texting was in there in the emergency rule, although I could be mistaken about that. But telephone calls, remote patient monitoring, and then communication through the secure electronic mail and secure portal, those are all still included. So there are several options for asynchronous telehealth. You're right, I don't see texting explicitly mentioned, but we'll try to get some clarification, get you a clear answer on that here soon.
How many total claims does Medicaid average? Do those telehealth claims numbers at the start of the presentation show increased visits overall, or does it show most visits have shifted to virtual? We're actually in the process of continuing to gather data as it relates to total telehealth claims volume and in-person visit volume. We're measuring that as a result of the COVID epidemic to determine how these things are sorted out. I don't have a number off the top of my head. Lynn or Stephen, do you have any numbers?
I don't have any specific numbers, but I know generally it is difficult to measure some of those things in real time simply because providers do have a pretty wide window of time, at least 6 months, but usually up to a year in order to be able to bill or submit claims. So a lot of that is going to sort of become crystallized as time goes on, but I don't know that we have any, I personally don't know any, hard encounter data right now to be able to share.
Next question, when do you anticipate this rule going into effect? I believe the presentation indicated that it was November 15.
That's right.
To clarify, OPH-BHs may only submit telehealth services rendered by a licensed psychologist or an independent practitioner, i.e. LPCC, LISW, LICDC.
This is Lynn, I can help with that. So that is not correct. So the outpatient hospitals can bill for all of the outpatient hospital behavioral health services, so the OPH-BH services, which includes a wide range of services that can be rendered by a very wide range of practitioners. And then separately, or in addition to that, the outpatient hospitals may bill for the services of a licensed psychologist or an independent behavioral health practitioner if the hospital chooses not to use the outpatient hospital behavioral health benefit. So it's two separate options.
The next question, I believe, is a billing question. Is the once per year in-person requirement by tax ID or by provider? I'll have to go off and talk to some of our folks that are more into the finer points of billing to get the answer to that question.
Yeah, I would agree with that. We can get some clarification. But again, I just point to the fact that it is a little bit more broad and easier to meet that requirement than it was in the last version of our permanent rules from last July. So hopefully it makes it easier than it was.
For the annual seeing of patients by another provider, does that need to be another provider in the same organization? I don't believe so. Stephen, what do you
Yeah,
think?
I don't believe so either. I think that is what it was in 5160-1-18 before, but that doesn't seem like the way it's written right now in the proposed rule that we just original filed.
Does absence of patient site allow Ohio providers to see a patient who is temporarily outside of Ohio, e.g. vacationing, staying with another parent for summer, college, etc.?
I'm not really sure about that either off the top of my head. On some of these scenarios, that are unique, we might have to have a more in-depth conversation to find out a few of the facts and find out exactly what's going on. But we certainly want to make sure that people have certainty and predictability with billing and when something will be reimbursed. So we can definitely talk more with you about that. It's a good question, but I'm not sure that I can give a definite answer just based off of the question right now. But we want to make sure that you do get an answer.
Well, we'll research this some more, but the
Yeah.
definition of the patient site is the physical location of the patient at the time the healthcare service is provided through the use of telehealth. So I guess the question seems to be if the patient site is outside of the state.
Oh, I see. Yeah, I don't see any, there, in the last permanent rule, there was a list of, here's the list of places where the patient can be in order for it to be reimbursed. That's completely removed. So I don't see any location restrictions on the patient. Again, someone correct me if I'm wrong, but I don't believe that there is anymore.
Not in the rule. I think
Right.
one of the things that the practitioner will need to consider is whether there are any questions about, does the other state allow out-of-state practitioners to provide telehealth therapy in that other state? And that may be the other state's licensure
Oh, I
board
see.
that would have to answer that kind of a question.
So if the practitioner is out of state, or if the patient's out of state, and then, are there any restrictions from that state's location that might impede their ability to render that care? It's a good question, but I don't know that we're able to answer that, or even address that in the rule. Would you say, Patrick?
I don't think we can. This scenario would be Dr. Jones is here in Ohio. His patient is in Kentucky. Can Dr. Jones conduct telehealth for his patient in Kentucky? And I don't know the answer to that.
Yeah, I don't see anything in our draft rule that would restrict that. But if there's some restriction on it from some licensing board, either in Ohio or in Kentucky, that may exist, but it doesn't exist within the scope of the proposed rule we just filed yesterday.
Does the change in service location exclusions apply to all behavioral health services? Lynn, do you have a thought on that one?
Yeah, so for the behavioral health, when you get a chance, I know folks probably haven't gotten a chance to dig into the rule. When you get a chance to dig into the rule itself, there is some more detail about billing for behavioral health services. So for behavioral health providers, there are specific place of service codes that are allowable for the behavioral health services. So you would refer to those place of service codes.
Will schools be eligible patient sites? Based on the definition of patient site in the proposed rule, I would say yes.
Yep. And they were in the permanent rules from before as well.
Can we start billing interactive complexity immediately? I believe, based on Lynn's comments earlier, it won't be available until November 15th, when the rule becomes effective.
That's correct.
Let's see, there are several behavioral health CPT codes not covered by Medicaid, but are covered by other commercial payers. Will Medicaid be expanding coverage for behavioral health codes?
So this is Lynn, and I think for whoever made that comment, if you could just follow up with us through, either through email or through the public comment process, and let us know which behavioral health codes you're seeing that there's not coverage for, and like we typically do, we can look into that to determine, if there's any services. But if you're speaking to services that are covered for telehealth, the vast majority of our behavioral health codes are available to be billed by telehealth. So typically we actually see the other way around, where Medicaid has a fairly extensive set of behavioral health telehealth codes, where other payers are sometimes more limited. So definitely would be interested in learning more about what you're seeing.
We've got another billing question. CMS and commercial insurance companies want to see location code 02 for telehealth, but these were previously denied by Medicaid. Will it be accepted with this new rule? I think we're just using the GT modifier. We aren't using location 02, are we?
And that's getting to a level of detail that I don't have off the top of my head, but I know we do have, I think there's an Appendix B to the rule that has some of those location codes as well. But just in the text of the rule, there's no restriction that I know of that simply states that these are the only allowable ones. So I don't know the details of what goes along with the O2, but that's something we can certainly get clarification on.
Yeah, location code 02 is telehealth.
Oh.
And so I agree, Stephen, this is getting to a level of detail regarding billing. So I would just encourage for each provider to make sure they're referring to the billing instructions for their provider type, because I know there are some differences depending on the provider type, which location codes are allowed.
Okay. And scroll to the next question. Did I hear that interactive complexity can now be billed under telehealth starting November 15th, when the rule becomes effective? What are the billing rules or protocol for Medicare, Medicaid patients that are in need of case management services? Medicare does not cover case manager, providers, or H0036 service codes. Yeah, I think.
Why don't we take that as a separate? We'll take these kinds of detailed questions back and do a little bit more research on those.
And this is not a, well, and then there was an individual indicating that they were having trouble hearing. Can we have the slides? Yes.
Mm-hmm.
If require a patient to be seen in person once a year, how can consultations on new patients be done? I think we'll take that one back as well.
Yeah, I believe there is something, I don't want to misspeak, but I believe there is some language in the actual text of the rule that speaks to when new patients can be seen through telehealth as well. So take a look at the text of the rule through the link. It should be pretty easy to find. It's not a long rule, only a few pages, but I'm happy to answer that question as well if you check through it and still have a question. But I do believe that is addressed in the rule somehow.
But can outpatient hospitals bill for speech therapy, occupational therapy, et cetera, or only behavioral health? This particular rule is for outpatient hospital services. We'll get back with you on this one.
Yeah, I think I know the answer, but I don't want to misspeak. So let's make doubly sure before we give you a definitive answer.
Is it pretty positive that this rule will pass and we can safely continue with our business plan to continue all of the services we currently provide via synchronous and asynchronous means? I think it's safe to say that nothing is certain. It's a legislative process. I feel confident in the public support for the rule that we have and in the process that we're undertaking. It's a formal rulemaking process. I think there is a high likelihood that we will be successful in completing the rule process. Stephen, do you have anything thought on that?
I think you're correct there. Yeah, we do feel confident simply because we are, maintaining, the vast majority of provisions that we received so much positive feedback regarding. So, I mean, obviously, nothing is certain, and anything you could do to help us get it across the finish line would certainly be helpful. So if you have the bandwidth to notify your legislator that we're going in the right direction, that certainly would be appreciated, but we definitely want to hear your comments as well too.
We had been told on March 26th that there had been a policy decision that interactive complexity cannot be used if a service is provided by phone or telehealth in general. I believe this was due to a prohibition in the CPT manual. Has this changed? I guess I'm lacking the context of.
Yeah, why don't you, if you would send us an email with a little more of the context for it, that would be helpful.
Okay. Will the slides be available? I'm seeing a lot of repeat questions coming up. Are there specific and/or different documentation rules for telehealth services? I think the documentation requirements for telehealth services are going to be whatever the documentation rules are for the service in question. Are you keeping an APRN's ability to order home health?
I don't believe that's addressed in the telehealth rules specifically.
Yeah, that's in an APRN rule or a home health rule. Can you revisit and clarify on crisis services? As the crisis center for the county, we may assess someone in crisis who is not open with any agency, and once assessed through crisis, we may never see them again. How can the once a year face-to-face requirement apply in these cases?
Yes, so this is Lynn. I think along with some of the other questions about the policy pertaining to the requirement to have an annual in-person visit, I think we've gotten some good questions. So I think we'll go back and look at those and be able to provide a little bit more guidance. And so if folks do have specific concerns or ideas about that policy, these are all good examples for us to take back and think about.
Are the codes listed in the appendix rule summary currently published in the fee schedule section of the ODM website?
I think the place to find it, if you follow the link that that's on this slide here that's being displayed. It'll take you to the rule package. The rule package is on the Register of Ohio, and that's where this will take you. And it has the appendix right there. So if you click that link, or if you go to that site, you'll see on the Register of Ohio displays the rule text, the RSF, the rule summary fiscal analysis, as well as the appendix, which has all of the codes that are applicable to this rule. So you can find it there. So it is published. It's not on our website because it's still a proposed rule, but you can find it here on the register where it tracks all of that.
If the rule is approved and becomes permanent, is it truly permanent, or does it only last for a certain amount of time? Well, all rules are subject to 5-year rule review.
That's right.
This particular rule does not have a sunset date, and would be subject to the 5-year rule review requirements.
Yeah, the term permanent rule is mostly meant to distinguish between emergency rule. Emergency rules by statute are only in effect for a certain period of time before they expire, unless they're supplanted by permanent rules, which this is. So yeah, if new rules are filed, like if you know, later in the future we were to file other changes to the rule, like that can still happen. But this rule is a lot more permanent than emergency rules. So I realize that it gets a little wonky into the rulemaking jargon, but I assure you, I did not create that jargon. That's all spelled out in Ohio Revised Code.
This is a question we may want to take back. TBS services having differing rates depending on location, community versus office. If originating site means where the client is located, if the client is at home or in community, can you clarify this location we now select despite the fact that the practitioner is in the office? I don't believe the rule uses the term originating site.
No, it uses patient site and practitioner site. And then, go ahead, Lynn.
Oh, I was just going to jump in here. That question, I believe, is pertaining to behavioral health services. And we've had a couple webinars specific to behavioral health providers and dug into some of these details around the rate differentials and the different sites. So we can make sure to share the links to those webinars as well as for folks who are interested in a little bit more detail. But to add to that, the originating site terminology, I believe, may be what is used in the mental health addiction services rules. So we can also follow up with some additional clarification around that specific to behavioral health services.
Was text messaging excluded as a policy decision or because it wasn't specifically named previously? BH providers were informed in the April MHAS ODM telehealth training that text messaging is an allowed asynchronous activity. As we indicated, we'll go take this one back and review that question. It's the rule that we're talking about, 5160-1-18, is actually silent on that.
Mm-hmm.
And that, I believe, is the last of the questions.
So thank you for excellent questions. We will be reviewing all of them, all the questions. And here again are 2 links for you if you think of additional questions. Just to summarize or kind of recap, since there were a number of questions about the rule process, so think of it as this particular rule is really specific to the reimbursement of how services are paid for. And so to the extent that any of your questions related to documentation or other things about the nature of that specific service, you'd want to look then in the service rule. And that's the cluster of rules that I mentioned just very briefly at the beginning, where there's more than 80, for example, in the area of long-term service and support. So the point is, because of this expansion of the use of telehealth, it touches many of the service rules, and we want to make sure that there isn't anything in those service rules that counteracts or minimizes the ability here. So, you'll want to look at this one or put this one in your in the context of or next to the service rule for the particular service that you're thinking about, particularly because our audience today obviously includes a lot of diversity, from behavioral health to hospitals to outpatient hospitals, individual practitioners, which we're delighted to have everybody. But feel free to use the email link for further follow-up. And just last, why don't we, Michael, go back to the timeline for just a minute, if you would. So just in closing, we've specifically timed the input and the the public hearing to be sure that we could hear your input and be able to make changes as necessary in time for this to be able to be permanent without causing any kind of a gap. So we would encourage you to be in touch with us as soon as you can if you have concerns about the rule. From today or now going forward, please let us know about your concerns, but understand that we also will have the October 1 public hearing, and the combination of comments that we get between now and October 1, as well as the comments we get on October 1, will inform any final changes that we make to the rule prior to the final JCAR actions, in order that so we can be sure there isn't a gap in that reimbursement. So plenty of time. We hope to get your questions, resolve any concerns you might have, and not have us disrupt or end up with a gap. So with that, we want to thank you for participating today. And again, thanks for everything that you do for the people of Ohio, and particularly those Medicaid individuals that you serve. Thank you, and have a great rest of your day.